Hi everyone, my name is Gianna Pascale, and today I'm going to be doing my presentation on factitious disorder imposed on another. It is labeled as F68.A in the DSM-5, and this is for Psychology 745. So, as for the diagnostic criteria of factitious disorder imposed on another, it's also known as FDIA. The first criteria is the falsification of physical or psychological signs or symptoms or induction of injury or disease in another, associated with identified deception. The second criteria is the individual presents another individual, the victim, to others as ill, impaired, or injured. Criterion C, the deceptive behavior is evident even in the absence of obvious external rewards. So the person's not getting gratification from getting money from this, it's all internal. The last criteria is the behavior is not better explained by another mental disorder, such as delusional disorder or another psychotic disorder. So the perpetrator, not the victim, receives this diagnosis. And to specify, it's either a single episode or recurrent episode, which is 2 or more events of falsification of illness and/or induction of the injury. So here's a little visual to show what the disorder is like and what the dynamic is between the two people. So again, the perpetrator, the one on the left, is receiving the diagnosis of factitious disorder imposed on another. It has been also referred to in the past as Munchausen syndrome by proxy. So on the left, you can see the motivation behind the perpetrator is vicariously experiencing the sick role through the person that they are caregiving for. And the victim is often falsely presented as ill, impaired, or injured. So some associated features with factitious disorder imposed on another. These individuals diagnosed are at risk for experiencing a great psychological distress or functional impairment by causing this harm to other people. Family, friends, and healthcare professionals are all affected by their behavior when they are given the opportunity to devote time to this person, to care and give attention for the patient and the caregiver in this relationship. And providing resources and medical care is really impacting that. So individuals with factitious disorder imposed on another sometimes falsely allege the presence of educational deficits or disabilities in their children, for which they demand special attention, oftentimes at considerable inconvenience for education professionals. So again, like the medical field is affected, that area of their lives, their education can also be affected by this disorder. Whereas some aspects of factitious disorders might represent criminal behavior, example FDIA, where the parent's actions represent abuse and maltreatment of a child, such criminal behavior and mental illness are not mutually exclusive, however. Such behaviors, including the induction of injury or disease, are associated with deception. So again, like the first criteria, it's all about the deception. It's not like a psychosis. They're not delusional. So as for the course for FDIA, factitious disorder is usually one of intermittent episodes. Single episodes and episodes that are characterized as persistent and unremitting are less common. So when it's imposed on another, the disorder may begin after the hospitalization of the individual's child. So maybe something did happen that triggered this caregiver sense in the perpetrator, and they felt like they had to continue with this. In recurrent episodes of falsification of signs and symptoms of illness or induction of injury, this pattern of successive deceptive contact with medical personnel, including hospitalizations, may become lifelong. So the course is usually lifelong. As for the prevalence of FDIA, it is unfortunately unknown, likely because of the role of deception in the population. So it goes underdiagnosed, misdiagnosed. But based on a study of general hospital inpatients in the United States referred for psychiatric consultation, it is estimated that almost 1% have presentations that meet the criteria for factitious disorder. Factitious disorder imposed on self or another appears to be encountered more frequently in tertiary care systems more than primary care sites. Due to the secretive nature of this disorder, like I said before, it is likely underdiagnosed. There's no definite threshold or defined threshold for this level of deception required to make the diagnosis. So it really is hard to discover. As for the prognosis, some people with factitious disorder suffer 1 or 2 brief episodes of symptoms, but in most cases, the disorder is chronic or long-term, like I mentioned before. It could be very difficult to treat. Imagine the perpetrator is really into this caregiver role. Why would they go seek treatment for themselves? That's not the side of the dynamic that they think they should be on. Again, like I just said, unfortunately, due to the low self-awareness, many people with factitious disorders will not seek or follow the treatment that is given or recommended. So for cultural considerations, while the prevalence is not known, a meta-analysis of all case series and studies finds that 2/3 of individuals with factitious disorder are women and 1/3 are men. So it is mainly taken by women. So cultural differences in caregiving may lead to misdiagnosis also. So confirmation or disconfirmation of a case requires a review of all possible family records, specialized forensic interviews with key informants, and formation of a multidisciplinary team. So you could just be seeing different practices and cultures in the sense of caregiving, but again, you have to go through all of the history to really get the evidence all together to make this diagnosis. It's a tough diagnosis to kind of gather. So for the history and signs of FDIA, a study by Emerson and Postlethwaite in 1992 suggested the parental responses to children occupy a continuum. So at one end of this spectrum is the parent who exhibits the classic neglectful behavior, maltreatment, disregarding the symptoms for the child who is truly ill. Whereas at the other end of the spectrum, the parent who fabricates or generates factitious symptoms in their child who is otherwise healthy. In between is kind of the norm, the parents who are appropriately concerned about a child's symptoms and who make appropriate efforts to seek care for the child when it is needed. Like I said before, it's not a delusion. FDIA is not a psychosis. The caretaker is voluntarily and consciously simulating these false reports and/or inducing symptoms of a problem and then taking the victim to then seek professional attention, disavowing knowledge of the source of the problem. So for example, in a show about this disorder, the mother was giving her daughter medication that paralyzed a dog's legs. So obviously her daughter was reacting differently to that medication, getting paralyzed all over. The mother was pretending she was not aware of where this medication came from and how she got it. The deception may arise from a desire for attention, anger, a need for control over others, or other intangible motivations. Like I said, in the criteria, it's not an obvious external reward like money. Perpetrator dynamics are poorly understood in most cases. So for some signs, if you're looking to diagnose or if medical professionals were suspicious, this is what they would usually look for. Inconsistent information that was provided by the parent of the patient, symptoms that are especially dramatic or out of proportion with the suspected diagnosis, inconsistencies among symptoms and exam findings, symptoms that are inconsistent with anatomy or physiology, inconsistencies with patient-provided information and past medical records. The parent resists the release of the patient's medical records. Obviously, if the parent's withholding information, that is very questionable. The patient has an extensive past medical history and may have numerous ailments. Extensive workup and no definite diagnosis. Patients may even have undergone invasive procedures or surgeries. So if there's a child at a young age who's gone through so many surgeries and there's no diagnosis yet, especially in this kind of age of the medical field, there's definitely a big question mark there. And then exam findings are contradicting what the parent provided information or what they're saying word of mouth is. So etiology for FDIA is largely based on speculation. There are no high-quality, large-scale studies demonstrating consistent etiological factors. However, observations have been made based on case reports and smaller-scale studies. Many experts consider factitious disorder to be largely developmental. It is thought that the behaviors exhibited are maladaptive responses to life events, especially during childhood. Patients with FDIA are more likely to have suffered a major childhood illness. It appears that for some patients, this early experience with the healthcare system is pivotal in the development of this disorder. One review of 20 cases reported that 60% of patients had a history of significant childhood illness. There is a strong association between patients with personality disorders and factitious disorders, and many overlapping behavioral traits are evident, further supporting the developmental theory. So, two proposed mechanisms behind the behaviors set above are the affection and attention that one may receive from the victim in the sick role, especially for those who never really sensed that during their own childhood when they were sick, maybe. And then a sense of accomplishment in duping physicians also is a mechanism behind that. As for the assessment of FDIA, these individuals are prone to dishonesty, like I said, with the deception. So diagnosing the condition can be very difficult. For a caretaker to be diagnosed with FDIA, they'll need to admit to the abuse and submit to psychiatric treatment. With attention focused on sick or injured child, it's easy for doctors and family members to overlook the possibility of FDIA. It's likely that the doctor will first try to diagnose the child with a specific illness. If a child repeatedly presents with unexplained illness or injury, the doctor may begin to suspect child abuse or FDIA. They may also become suspicious if any symptoms suddenly stop or improve when the child isn't with their caretaker. Remember, it's the adult, not the child, who is being diagnosed with FDIA. So as for treatment for a factitious disorder imposed on another, so first and foremost, it'd be most important to place the victim in a safe environment and give them therapy to cope with what their experiences just were. The person accused of child abuse will likely face criminal charges, depending on severity. If FDIA is suspected, psychiatric counseling will be recommended. However, treatment may be difficult if the caretaker doesn't admit that there's a problem. So, for the goal of psychotherapy, to help the person identify the thoughts and feelings that are contributing to the behavior and to learn to form relationships that are not associated with being ill or taking care of someone and getting attention and affection in that way. Individual or family therapy may help all the parties cope with the situation. So for some differential diagnosis, malingering could be seen, but it's differentiated from FDIA because the intentional reporting of symptoms are for personal gain, like money or time off work. In contrast, FDIA, there's no like external reward. This malingering are not mutually exclusive with each other. Another is deception to legal liability and conversion disorder and somatic symptom disorder. Both of these involve subconscious processes, which may be difficult to distinguish from FDIA. However, to make the distinction, it's imperative to find the objective evidence of the deceptive behavior. So for my case presentation, on the right, I did make up a case myself, but on the left, I did provide a real case example because it's kind of prevalent in the times. Daisy Blanchard was diagnosed with FDIA because of the role she played as a caregiver to her child, Gypsy Rose Blanchard. I'm bringing this up, and it's significant because Gypsy Rose Blanchard is released from prison on December 28th, 2023, after murdering her mother because of their case. So as for my own case that I made up, here it is. Julie is a 36-year-old nurse who had recently moved in with and given the caregiver rights of her mother, Hannah, who is 65 years old, as a result of the sudden death of her presumed-to-be healthy father. In the beginning of her time living with Julie, her mother was relatively healthy besides having rheumatoid arthritis, which caused her to have weak joints. In the past year, however, Hannah has been taken to the emergency room multiple times for dizziness, high blood pressure, and even 2 seizures. The clinicians thought this was strange since Hannah's medical and family records indicated no history of high blood pressure or seizures. Julie was always with her mother on these visits, and she expressed extreme distress and fear for her mother's life. After the doctor's suspicions arose, Julie had already transferred her mother to a different hospital. About a week following this occurrence, the police arrived at Julie's new home with an open investigation because the concerned medical staff at the first hospital noticed an alarming pattern of Hannah's visits to the emergency room. So, with this information, I would say that Julie may be diagnosed with factitious disorder imposed on another, and the victim being her mother. So I get this information because around the time Julie moved in with her mother, she presented with an illness that was falsified as verified by her physical and history of her health. Julie always accompanied Hannah to the hospital, acting extremely distressed. There were no obvious external rewards, which ruled out malingering. Once suspicion arose, Julie moved Hannah to another hospital, which is a sign that she was caught in her deception. And as a nurse, Julie may have the knowledge to falsify these symptoms, knowing what medications may react and not react well with another. So that was my presentation. Thank you all for listening about factitious disorder imposed on another.